In this lecture, we're going to continue our discussion of the pressure-volume relationship in the lungs and how that drives ventilation. And so this first slide is recapping what we talked about on our previous in one of our previous videos, and that's the relationship between pressure and volume. And so always recall that volume changes will generate pressures that will move air. And so when we think about the pressure, the whole goal here is to try to manipulate the volume in order to get air flowing from outside of our bodies or from inside of our bodies to the ambient environment. And so just to review Boyle's law, so Boyle's law is that fairly straightforward, fairly simple law that describes the inverse relationship between the pressure of a gas in a container and its volume. And so we have our molecules inside our volume cylinder, and those molecules will exert a particular force against the interior walls. The same four molecules will apply the same force, except that they're not going to be interacting with the walls as much when we expand the size of that container. And in expanding the size of the container, what we're doing is we're increasing the interior surface area. And so even though each particle would still hit the interior wall with the same force, that force is spread out over that larger area, leading to a decreased pressure exerted by the same four molecules that we have on the right that we did here on the left. An important component to these pressures comes from some additional tissue between the lungs and the chest wall, and those are the pleurae. And so the pleura is a thin sac that covers each lung, and it also provides a connection to the thoracic wall. And that outer layer of the pleura is what's called the parietal pleura. And so the parietal pleura, which has a connection to the lungs, helps to maintain the position of the lungs in the thoracic cavity by connecting it to that chest wall, and it's also continuous with the heart. The inner layer is referred to as the visceral pleura, and so whenever you see the term visceral pleura, that relates to the internal organs, the viscera of the thoracic cavity. So that's always going to be the inner layer. And that's attached directly to the surface of the lung, and the lungs through the visceral pleura are attached to the cell wall by the parietal pleura. Now that sets up a very small space between the visceral and the parietal pleura, and that very small space is critically important to lung function, as it does two things. It helps to lubricate the membranes of the lungs to reduce friction, and in doing so it allows the lungs to move and expand and to contract effortlessly. If there was a lot of friction, then our muscular system would have to exert more force to cause that expansion in lung tissue. So if we take a look at the picture here on the bottom of the slide, we take this very small image of this portion of the lung, and we see that the visceral pleura is that inner lining, the parietal pleura is the outer lining that has a connection to the thoracic wall, and it's very small, very thin, but very important space between those two layers, which is lined by this fluid. And this fluid is very important, as I'll detail on the next slide, because this fluid helps not only to just reduce the friction, but it helps to keep the lungs inflated. And so before we get into that, we need to define a couple of things. The intrapulmonary pressure refers to pressure within the alveoli. In a previous video, we used the term alveolar pressure. So alveolar pressure, intrapulmonary pressure, these terms are going to be used interchangeably. And so obviously this value changes, it increases and decreases with breathing, and is affected by muscular action, as we described in an earlier video with respect to the diaphragm and the other muscles, as well as the presence of molecules inside the alveoli. The intrapleural pressure refers to the pressure contained within that very thin but important layer between the visceral and parietal pleurae. And this also fluctuates with breathing. So as the lungs expand and contract, that will drive a small change in that pressure in that thin space. The important point to take here is that the pressure within that small space, the intrapleural pressure, will always be less than the intrapulmonary pressure, the pressure inside the alveoli. And to illustrate that importance here in this drawing, here we have the outer parietal pleura. Here we have the inner layer surrounding the lung itself, which is the visceral pleura, and our pleural cavity between the two. And that sets up a transpulmonary pressure. So if we imagine, just using a sample value here of intrapulmonary pressure of 760 millimeters of mercury, or a relative value of 0, we see that the intrapleural pressure is slightly below that at 756 millimeters of mercury, or relatively -4. So the intrapleural pressure is essentially a vacuum relative to the interior of the lung, and that's important because it helps to maintain lung inflation. So that because of this vacuum, this vacuum will always provide a force that will pull the lung out towards the parietal pleura. Without this pressure, the lungs would essentially collapse. Now, what's very important is that we have a way to measure these lung volumes as they change, which indirectly is a reflection of the muscular capability to manipulate those volumes, and that's what's used with spirometry. So spirometry is a technique in order to measure how much air flows into the lungs, how much air flows out of the lungs, and we can assess the state and the capability of our ventilatory muscles to cause those volume changes. And so we'll take a look at some of these very defined tracings here on the next couple of slides, but we need to go through a few definitions first. And those definitions include what are called pulmonary capacities, which are sums of pulmonary volumes. And so the first volume here that we'll talk about is the tidal volume. And this was defined on an earlier video, and we'll define it again here. And this is the amount of air that's moved during quiet breathing. So when you're sleeping, for example, that reflects how much air is moving in and out of the lungs, and that's about 1/2 liter per breath. The inspiratory capacity is the capacity of a person to bring air into their lungs. So that's going to be the sum of what a person normally moves when they're resting, plus what's called the inspiratory reserve volume. That's the amount of air that we can forcefully pull into our lungs with a voluntary effort. We have something called our functional residual capacity, which is the sum of the residual volume, and the residual volume is how much air is in the lungs when we've tried to push out all that air. So that reflects the amount of physiological dead space. Remember, we never completely evacuate all the air out of our passageways, because that would collapse the whole ventilatory system. So that little bit of air is what is called our residual volume. And we add that to how much air we can forcefully push out of our lungs, which is the expiratory reserve volume. That together is what we call our functional residual capacity. Our vital capacity is the sum of 3 volumes. That's the tidal volume, that's the inspiratory reserve volume, how much air we can forcefully pull into our lungs, and the expiratory reserve volume, how much air we can forcefully push out of our lungs. And that's the amount of air that's vital to our health and to our existence, because there are situations where we have to increase how much air we pull in. There are situations where we have to increase the amount of air we push out, and that climbs above what we would normally move under resting conditions. The total lung capacity reflects the anatomical structure of the lung, and that's when we add up the reserve volumes, the tidal volume, and the residual volume. But make note here that it's the vital capacity that reflects our ability to move air. The total lung capacity, because it incorporates the residual volume, that's the amount that's always in the air passageways, and that's the amount that we don't manipulate. So this is a typical tracing, typical spirometry tracing, and we'll start with what we defined earlier as our tidal volume, or TV, and that's about half a liter per breath. As we can see that we inspire, we expire, and we move that air. If we ask a person to perform a maximal inspiration, so to take in as much air as they can, we can see that we move beyond the half a liter that is moved during a quiet inspiration and expiration, and we can increase the amount of air by about 3 liters. When we try to push air out of our lungs, that's our expiratory reserve volume below the tidal volume. But we can see, what we see here is that we don't have anywhere the capacity to push air out of our lungs as we can to pull air into our lungs. So we have in this graph inspiration on the superior side, expiration on the inferior side, and our tidal volume is what is reflected here under resting conditions. Our total lung capacity factors in our inspiratory reserve volume, our expiratory reserve volume, as well as our residual volume. So recall our residual volume, that is reflective of our physiological dead space, because we can't evacuate all the air out of our lungs, even when we try to force all that air out of our lungs. One of the important factors that will allow us to expand, as well as allow the contraction of lung tissue, is something called lung compliance. And this is the ability of the lungs to stretch. It's a very important concept, because without the ability to stretch our thoracic cavity and our lungs, we wouldn't be able to bring air into our lungs. And it's a simple equation which reflects the change in volume divided by the change in pressure. A very compliant lung will be able to expand without a very large pressure change. We'll take a look at a graph on the next slide to illustrate that point. So the overarching question that we ask here is, how much pressure does it take, or how much force is necessary to stretch the lungs? Remember, we have to stretch the lungs to generate ventilation. Without ventilation, we won't be able to engage in the amount of external respiration to support life. There are two major factors that affect lung compliance. The first one relates to the actual tissue that makes up the lungs. So elastic tissue elements, these are the elastic fibers that have to be able to stretch, but will also recoil back to the pre-stretch state, that will cause the alveoli to decrease in size. And that decrease in size is important to increasing the pressure to push air out during an expiration. The alveolar surface tension, which is loosened up by the secretion of surfactant by type 2 pneumocytes, will also be a very important factor in ensuring that the alveoli will be able to stretch. Without an adequate amount of surfactant, that phospholipid, the alveoli will be very tightly held together, they won't be able to stretch, and we won't be able to engage in respiration. So we'll use a fairly straightforward graph to illustrate the relationship between pressure and volume. So if we put pressure here on our x-axis, that will dictate the change in volume. What we see here is a normal, healthy lung. And in that normal, healthy lung, it's going to require a certain change in pressure. So we have to cause a change in pressure in order to cause a particular change in volume. Basically, that's stating that in order to stretch lung tissue, it's going to require muscular force to do that. Now, here in the red, we see a very steep volume-pressure relationship. And so what we see here in this very steep relationship is that we have a very small change in pressure. So we have a very small amount of force applied, causing a very large change in volume. So at first this might seem energetically efficient, but remember, when we have the ability to stretch something very easily, that tissue has to be able to recoil as well for normal function. This kind of relationship is what we typically see in emphysema. And so this is a lung disease that is defined by the destruction of connective tissue. And it's the connective tissue that provides a very important factor to the structural integrity of the lung. Without that connective tissue, the lung tissue becomes very loose, and it just requires a little bit of pressure to cause a big change in the volume of that lung. The problem with that is that without that connective tissue, that lung tissue won't be able to recoil and push the air out, so a person is dependent on those expiratory muscles to cause that decrease in volume, increase in pressure for expiration. So it becomes very energetically inefficient as a mechanism of breathing. On the opposite side of that normal healthy lung is a lung that requires a very huge, very large application of force to produce a very small change in volume. And this is characteristic of a fibrotic lung or fibrosis. And in this particular case, we have additional fibrotic, very stiff tissue that gets laid down in the lung, and that enhanced stiffness makes it so much more difficult to cause a volume change. And remember, we have to be able to change the volume of the lung to produce a change in pressure to get ventilation going. And so really what's necessary here is that a person would have to generate much more force than normal to distend the lung. And so instead of just relying on the diaphragm would be active to a greater extent, as well as the external intercostal muscles, to cause that expansion of the rib cage. So this ends our video here for part 2 of the respiratory system, and then we'll move on to cardiovascular system part 1, where we'll talk about the blood, and then we'll pivot back to the respiratory system.